Hi, my name is Shannon, and today we'll be talking about identifying and responding to microaggressions. And we only have a few minutes, so we'll only be scratching the surface of this topic, but I hope we can use this to continue this conversation. Just to cover the ACGME clinician educator competencies, microaggressions really covers several of the competencies, including universal pillars, diversity, equity, and inclusion in the learning environment, educational theory and practice, and well-being. So first, what are microaggressions? This was a term that was first used by Dr. Chester Pierce, who was the first Black full professor at Massachusetts General Hospital. He was a professor of psychiatry. And he used the term microaggression to describe brief and commonplace daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults that potentially have harmful or unpleasant psychological impacts on the target person or group. There's a lot to unpack just in that one statement, but just to highlight some of the key aspects, the microaggressions are brief and commonplace. They're indignities. They can be intentional or unintentional. They're slights or insults that have potentially harmful effects. And just to also note that it doesn't necessarily require negative intent from the perpetrator, but the focus is more on the harm that is caused. So where do microaggressions come from? They really derive from individually held biases that are both implicit and in some cases explicit. They're due to structural and institutional racism and marginalization of minoritized groups. And just to note that we'll be focusing mostly on microaggressions in the United States, although they definitely exist in other countries and cultures as well. And then in particular in medicine, it's through the underrepresentation of certain groups, including racial and ethnic minoritized groups, and then traditionally held gender norms. Who perpetrates microaggressions? It could really involve anybody in the nexus of patient care. So that can include patients, clinicians, including attendings, trainees, students, and then staff members. And really anybody in that among those can be a perpetrator or recipient of a microaggression. But for the purposes of this talk, we'll be focusing mostly on microaggressions that are directed toward clinicians, in particular trainees or students. Now, there are several different types of microaggressions that have been described in the literature, and these can be based on really any aspect of anybody's intersectional identity. I think the ones that we commonly see are microaggressions due to race, ethnicity, language, gender identity, sexual orientation, ability, religion, body, habitus, although there are certainly others. And there are three types that are commonly described in the literature. The first is a microassault. These tend to be overt and intentional and could even be considered macroaggressions. So this is when you see overtly, unequivocally racist language as an example. So if a patient stated Blacks shouldn't be doctors. Then moving on to microinsults, these are more subtle and usually unintentional. One example of this would be if somebody stated, you were really good at expressing empathy in that family meeting, especially because English isn't your first language, with the insinuation being that people for whom English is not their native language, that they would have challenges leading a family meeting. Or something that I've encountered myself, being mistaken as a technician or a nurse rather than a physician. And then finally, there are microinvalidations, which are subtle and almost always unintentional. And one example of this would be if you were discussing, for example, microaggressions, and somebody in your discussion was saying that people are oversensitive when hearing about, say, a woman's experience with discrimination. Now, those are interpersonal microaggressions. There's also environmental microaggressions. So that's when the types above are reflected in the workplace. Some examples of this would include a conference hall of dignitaries from a hospital or medical school that only included portraits of white men, or generally a lack of diversity among a class of medical students, residents, faculty, or folks in leadership positions. And now there are several important ramifications of microaggressions to note for trainees and clinicians, and also I'll say trainees and students. It can really lead to feelings of isolation and feeling devalued, and can really disrupt the formation of professional identity, which, as we know, in the early years of medical school and residency is so crucial to development. There's been studies showing that people who receive microaggressions have higher rates of depression, anxiety, substance use, and possibly even suicidal ideation, as well as a study that suggested microaggression was associated with increased rates of hypertension. So generally, this can lead to an unsafe learning environment and overall lead to a decreased number of underrepresented in medicine going into the field. And it's key to note that this decreased work performance could be associated with worse patient care. Now, patients can also be recipients of microaggressions, and if they are, it can lead to feelings of inhumanity, can really disrupt that patient-clinician rapport, and then also lead to decreased quality of care. Now, how to best respond to microaggressions. This is a very challenging thing to do, certainly, and we as attendings will likely have a duty to play that key role as a bystander and ally. And that's because the recipient of microaggressions possibly could be too raw in the moment to respond, or because of power dynamics in the medical team make it such that the recipient, if they're a trainee or student, for example, would be less comfortable responding. Now, there is a lot of different proposed frameworks for how to best respond, and I'll share a few, and hopefully one of these is one that will stick with you and you can use. First is open the front door, standing for observe, think, feel, and desire. So state what was observed, how the comment was or could have been interpreted, how the recipient may have felt, and then what the desired outcome would be of the remediation. Next is the action mnemonic. So first, ask a clarifying question, come from curiosity, not judgment. Tell the person that you're discussing this with what you observe using facts. Explore the potential impact. Try to own your own thoughts and feelings rather than speak for others. And then state next steps. One simple framework that folks like to use is XYZ, which says, I feel X when you say Y because of Z. And then finally, there's grit. First, gather your thoughts, pause, and don't react with anger. Either restate what you saw or ask the speaker to restate what they said. And then that allows the speaker to clarify what they stated, and through that process could even realize the potential negative impact that their statement may have had. For I inquire, try to dig deeper, seek clarification, and again, come from a position of being non-judgmental. And then finally, talking it out. And this doesn't have to necessarily happen in the moment of a microaggression, but there's also opportunities for follow-up at later times. Now, here's some other tips that you can use for responding, and I'd like to thank Dr. Cricket Fisher, one of my former colleagues, who's a hospitalist at Brigham and Women's, who helped lead a lot of microaggression trainings for attendings and for trainees. One that I really like to use is preparing your team. So when you start your block, use that opportunity during introductions and how you like to run your team to discuss how you likely will encounter microaggressions and decide as a team how you would like to best respond to them, as far as who will lead the response, when discussion will occur, and which frameworks or which other tips you'll rely on. There's several more here that I won't read out for you, but just to know that you can refer to this slide. And I'd say that for certain scenarios, it's certain tips can be employed to your benefit. I'll just say that it's also, if you ever find yourself needing help, and again, this isn't easy at all, don't feel shy to escalate anything to your superiors if necessary. And again, this is not easy. There's certain aspects of this that make it especially hard, like if a perpetrator of a microaggression is more senior to you, or if a patient is the perpetrator. And this can certainly damage team dynamics, and there's other reasons why this is very challenging. So know that you're not alone. For microaggressions involving residents, you can always go to the program director or the GME office. You can, for microaggressions in particular that target underrepresented medicine folks, you can always go to DOM, Office of Equity, Diversity, Inclusion. And then UCLA Health also has a heady office. And then for students, you can also go to their to the School of Medicine and administrators there. So some takeaways from this brief talk: microaggressions, they derive from individually held biases and then systemic and structural marginalization of certain groups. Usually they are subtle and unintentional statements that harm recipients. that lead to unsafe learning environments, potential psychological and physical harm to recipients, and then worse quality of patient care. Keep your eyes and ears ears and eyes peeled for microaggressions, because you likely will encounter them, even in a brief block on service. Whenever possible, attempt to respond. This will allow you to display allyship with the recipient, and can help build toward a positive learning environment for your team. Here are some references you can refer to if you'd like to read more.